Hello, Insta family. It's Dr. T here. It's rapid fire Q&A Tuesday night. Better get my motivated pants on to answer any questions that you might have coming through. How are you guys? For a Tuesday, not too bad. I've just been in sunny, not sunny Melbourne for the weekend at a CREI exam preparation weekend. Well, the funniest thing about CREI is you as the examiner have to do the exams. So you actually go through the exam process again and again and again. It's like a horrible nightmare roller coaster you can't get off. I mean, it certainly keeps you current with your knowledge, which is great, but to face the music in front of your knowledgeable colleagues every single year is slightly stressful. So yeah, I was literally put on the spot for a number of scenarios, but it was good fun. Anyway, good fun. So lovely to see you guys. I hope you're really well in the rundown to Christmas. I could not believe I went into the shops on the weekend and the Christmas stuff's all out. It's not even Halloween yet, so I better start the preparations. All right. Oh, Kayla Jameson, well done. Thank you for coming right out of the blocks in our lead up to Melbourne Cup with a fantastic question. Now, just quickly, guys, guidelines on questions. Keep them short and sharp. Make sure they're fairly generic. Don't lead your life story. I'll be giving you a short, sharp, generic answer. And so, Kayla, thoughts on HyCoSy. Is this something you would refer people for? Yes. It is a test that I refer people for. So HyCoSy is done. So there's there's a couple of ways, 3 ways actually, of testing tubal patency. First way is keyhole surgery, laparoscopic surgery, where we actually visually watch ourselves pass a blue dye through the fallopian tubes in the middle of surgery. Am I going to put you off to sleep just to do a tubal patency test? No. So we often do it at this time we're doing other surgeries such as resecting endometriosis. A hysterosonogram is done in an ultrasound department by a radiographer working in a radiology department, and that is where you pass contrast through the cervix, up through the uterus, and take an x-ray through the abdomen and watch it pass through the tubes. And an HSG can be quite uncomfortable, so we always recommend that you take pain relief prior to going and having it done. And it's also quite, I think, uncomfortable from the perspective that it's quite a clinical environment and often not necessarily done by somebody who works in women's health all of the time. Now, an HyCoSy is actually a similar process, but it's done by a women's imaging specialist. So someone who does ultrasound, and they, again, pass a little tube through the cervix. And this time they're passing some fluid like agitated saline through the tubes. But this time they're watching with ultrasound. And the benefit to that is you can also look at other features on ultrasound at the same time. You can look at obviously the outline of the endometrial cavity. You can look at the ovaries, do the antral follicle count, look to see that everything's mobile, see polyps, see fibroids, where you might not necessarily have that kind of detail in an HSG. Can it be equally painful? Yeah, it can be. So again, I would be suggesting that you take an anti-inflammatory before you go along for either of those procedures. So yes, I definitely refer people for it. Do I refer all of my patients for it? No. If someone has male factor infertility, such as a low sperm count, and we know we're going for IVF, there's probably no point in doing an HyCoSy. I generally would refer it for someone who we might want to prove they do or don't have tubal patency, perhaps because you're considering something like ovulation induction treatment, or if we are unexplained, we don't know why somebody is conceiving and we want to see if flushing the tubes, A, proves that the tubes are open, but B, might also be therapeutic. So hopefully that's helpful, Kayla. All right, any other questions? Elf Jones, do you have any tips to extend luteal phase other than progesterone supplementation? Well, the luteal phase has a defined period. That is 14 days. So you don't want to extend it any further than 14 days. Whilst there is some controversy as to whether luteal phase defect or a shortened luteal phase actually exists, remains controversial. But often that luteal phase actually reflects what's going on in the front half of the cycle, in the follicular phase. So if you have an ovulatory issue, if you're poorly developing an ovulatory follicle, often you're affecting the back half of the cycle as well. So the first thing to do is optimize ovulation if you have disordered ovulation. And then if you have a corpus luteum from where you've ovulated an egg, you can sometimes prolong its lifespan by actually continuing to stimulate it with HCG. You might know that as Ovidrel or Pregnal. So other ways of supporting that luteal phase is actually to just continue to support the corpus luteum, or you give the lining the byproduct of the corpus luteum, which is progesterone. So hopefully that has helped to answer that question somewhat for you. Lovely to see everybody. Diane Werrett's on, Cody Kennedy's on, Sparkling 786, Manda Durack. Lovely. Oh, here, Sparkling 786. How many IUI cycles should you do before moving on to the next treatment? Well, if your doctor has prescribed IUI treatment, you need to understand the prognostics of that. So we generally reserve IUI treatment for a couple who have unexplained primary couple subfertility, so can't figure out a reason why they are not falling pregnant, and generally young. So for me, arbitrary threshold of about 35. I don't think I'd bother offering it to a couple over 35. And what we know to be true is that it really only doubles your background chance of conceiving. So remember, the longer you've been trying to conceive, the lower your chances next month are of conceiving. So it's not going to be 20%, right? Because if you've been trying for 12 months, your background chance each month of falling pregnant is not going to be 20% anymore, because there's something going on. So when you look across the board, across Australia, success rates for IUI sit at about 15% chance of a positive pregnancy off an IUI cycle. It's not fab, is it? So I would not labour much beyond 3 cycles. By that point, if you're not successful, there's something else going on and you really need to move on in treatment. Not only that, but it's been some treatment. It is. So the last thing we want to do is exhaust you before we move you on. So that's my thoughts about IUI. Jazz Great Rex. Why would progesterone not return to baseline after a failed cycle? Why would it not return to baseline? Lots of different reasons. You could have a follicle that's continuing to produce progesterone. You could be taking some alternative preparation that is interacting with the assays. I'd be doing an ultrasound to make sure that there is no other cause. Incorrect assays, unlikely. Maybe more time is required, but often it's a functional follicle, a functional corpus luteum that's producing progesterone. So yeah, maybe more time. Sugar Kitten, what can help with issues with progesterone receptors? Not very much, to be honest. Mostly it's an inherent issue. The relevance of, progesterone receptors is that there is a theory that in women who have endometriosis, their progesterone receptors are not normal. And in fact, you might need sort of supraphysiological amounts of progesterone because the lining of a woman with endometriosis is probably not normal. That's why their pregnancy rates are relatively lower compared to perhaps other women who are going through IVF for different reasons. So really, it's about flooding the receptors with more progesterone. Research area. Not a lot of info on it, to be honest. Okay, any other questions? Come on, there's got to be more questions here. Oh, did I miss one? Nope, got the one from L. Jones. Can't see any earlier on. Any more questions, everybody? Nope. You're welcome. You're very welcome, Sparkling 7 to 8 6. Very welcome. I had a radio interview today while I'm waiting for more questions. Had a radio interview today with ABC Drive talking about the increasing pregnancy rates and increasing fertility treatment rates over COVID. So if you're interested, it's on their website, ABC Drive. I don't listen to the ABC very much, so yeah, go and have a listen to it. Interesting stuff. Okay. Abby Hunt, when would you recommend an endometrial biopsy? Depending on what you're biopsying for, my friend. I'm assuming you're talking in the context of recurrent implantation failure, so the creation of chromosomally normal embryos, good quality embryos, putting them back, not falling pregnant. That's probably when you might consider, is there some sort of luteal phase endometrial receptivity issue? Do you have sort of a chronic endometritis? So in the context of recurrent implantation failure, talk to your fertility specialist about it. The actual act of taking the biopsy, which we term an endometrial scratch, has pretty much been disproven to improve implantation rates. So it wouldn't be for therapeutic reasons, but rather diagnostic reasons. GGM2P, lovely to have you back. Can hypothalamic amenorrhea and PCOS exist? Yeah, probably. I certainly have seen fusion patients. So perhaps those who've had PCOS, manage their lifestyle with regards to losing weight or increasing exercise or moderating diet, and then completely pendulum the other way. So they kind of don't quite fit the criteria for PCOS, but they do have disordered ovulation. So yeah, I do think that they can simultaneously exist, difficult to manage. Trudes86, when would you suggest looking for endo? What are the markers or symptoms to look for? Oh, this is the age-old question, Trudes86. So 40% of couples who present for infertility, just infertility, not other symptoms, but just infertility, have endometriosis. Endometriosis symptomatically can present from weight loss and fatigue through to IBS-like symptoms, painful periods, painful sexual intercourse. There have even been people present with endometriosis coughing up blood. I know, right? Endo deposits have been found in the lungs. So this is sometimes a really insidious disease and difficult to diagnose. That's why, on average, it takes 7+ years to find a diagnosis of endo in a woman. When would I go looking for when would I go looking for endo? Definitely if there were signs of it on an ultrasound, so immobility of organs or big whopping endometriomas or endometriosis deposits. If someone was symptomatic in the context of subfertility, I think that it's very reasonable to be talking about a diagnostic laparoscopy for sure. Kayla, success rates. Oh, Kayla, second question. Success rates of pregnancy after an HyCoSy, based on your experience, I've been told it is higher the first month after. There's some data that shows that tubal flushing, whether it's through HyCoSy or mostly it's through the data published is using ultrasound, is that you can increase pregnancy chances in the 6 months afterwards, and that is most well proven. That's really bad grammar, but a randomized controlled trial done comparing Lipidol tubal flushing to normal saline tubal flushing showed a significant increase using Lipidol. So if you're doing it for therapeutic purposes, Gem Laurie, what does hysteroscopy look for? Just dropped out. You can do a hysteroscopy looking for polyps, fibroids, adenomyosis that's invading into the cavity. You can do it to sample the endometrium to look for, let's say, chronic endometritis. You can use hysteroscopy to look at the shape of the uterus to see if there's a septum coming down the middle or even a fibroid protruding into the cavity, or to actually assess a Müllerian anomaly, so perhaps a unicornuate uterus where there's only one side and one tube present. So hysteroscopy is a really useful test where you can look and you can also diagnose and treat at the same time. Oh, the questions are flooding through now. Right. Oh, I answered them all. Rapid fire. That's what it was, guys. Rapid fire Q&A. Well done. I'm hoping that has been really helpful. I reckon we had about a dozen really good questions there, covering all aspects of fertility. I want to remind everybody that November is our fertility nutrition month. Ooh, fantastic. One of my favourite subjects. And not next Tuesday, because that would be Melbourne Cup, and I would imagine there will be a few fertility nutrition people that might actually be celebrating Melbourne Cup. But the Tuesday after, so Tuesday the 8th of November at 5:30 Perth time. So that's 8:30 East Coast time. We are going to have Steph from the dietologist, amazing accredited dietitian, who's going to come on to our live and talk about, well, what is a fertility dietitian? What do they actually do? How can they help, and how can they assist fertility specialists to improve outcomes? So that's going to be amazing. So Steph from the dietologist, you can go and check her out on Instagram. She also has a podcast as well. I think we've promoted it here on my Instagram. So that's going to be November 8th, 5:30, right? So we're not going to do our rapid fire at 7:30 Perth time. It's going to be at 5:30, which is also 8:30 Sydney time. And then I'm going to go and get on a plane to Belgium to go to the International Society of Fertility Preservation. But the following Tuesday after that, I will be back. Yes, it's a rapid turnaround. And then the Tuesday after that, so I'm not very good at maths, but I think that would be the 21st or 22nd, we're going to have Nick Nation, accredited dietitian from Womb, who is also a fertility dietitian, going to come on and share a few stories with you about some really fantastic success that he has had in the world of fertility and dietetics. So, saving up all of your questions for those guys, I look forward to having you guys online next Tuesday, 5:30 Perth time. See you then, guys.